Good evening, everyone, and very warm welcome to all of you in this pre-Diwali night. And it's the festival of lights, and we are all going to be enlightened by a fantastic faculty tonight in this pre-course online workshops of the greatest, biggest, and the finest practical concept-based workshop conference called Spine Bootcamp. As you are all aware, Spine Bootcamp is scheduled from the 8th of November, Friday, onwards till the 10th of November. 3 days of intense concept-based practical workshops, 18 such modules, and much more is going to be on the display, and a lot of hands-on experience to train and to cherish your reflexes to make your experience in Academy of Spine Surgery the best that you can ever have. Mind you, it is only a beginning of the biggest conference that is going to showcase from the 8th to 10th November. And to have curtain raiser, these two workshops which are scheduled today on the 30th of October, pre-Diwali workshop, and also the next one coming up on the 6th of November, just a week from now, on another very important aspect of communication and presentation skills is going to be scheduled on the same time on the 6th November 2024. I take this opportunity on behalf of the organizing team of Spine Bootcamp and Bombay Spine Society to welcome you all to this wonderful workshop that is going to happen in next 2 hours. I also take this humble opportunity to welcome our distinguished faculty, Dr. Bharath Dave sir, Dr. Amit Jhala sir, who have spared their valuable time on this weekday. Yes, it's Diwali time, I'm sure. We'll set you free soon, sir, so that you can go back and join your family for the celebrations in the next hour or so. I also take this opportunity to welcome Dr. Arvind Kulkarni, Dr. Chhabra, Dr. Sukumar Sura, and Dr. Umesh Srikantha. Just to set the tone right, we will be having talks on technology more than the technique related to the 6 important and the most innovative aspects of spine surgery, followed by questions after every single talk. Why these talks, why this innovation, why this technology is important, and what more is happening in Spine Bootcamp, my fellow colleague Dr. Balamurli will showcase to you. I again take this opportunity to welcome you all, and I wish you all a wishful learning for the next 2 hours and the weeks to come to the Spine Bootcamp. Welcome to the curtain raiser of Spine Bootcamp. Over to you, Dr. Bala.
Yeah, thank you, Vishal. Once again, I welcome all the esteemed faculty who have taken their time off, especially just before Diwali. I can still hear the firecrackers outside. I've closed everything around to be here with you all for the next 2 hours. The concept of Spine Bootcamp is to create awareness about the technology that we use in spine surgery. As a spine surgeon, we all train for many years on the knowledge, on the skills, on how to be safe, how to choose the right patient, how to execute our procedure. But what is happening alongside this whole process of learning is that we need gadgets. We need gadgets like what we have listed down here: an ultrasonic curator, navigation, a robot, or an endoscope, or an O-arm, or various other things, microscope we need for us to do surgery safely. And in this process, we have to learn about this. Like we learn a technique, we have to learn about the technology as well, because the technology really helps us. It makes so many things easier. When we discuss with our patients, now we say we start comparing open surgery versus minimally invasive versus endoscopy. And we tell patients that, okay, this is safe. This is why we do this procedure. But as surgeons, we also know that an ultrasonic curator or an ultrasonic bone scalpel can reduce your time of doing your laminectomy. Using a navigation to do a TLIF can reduce your time of doing your navigation surgery. So a robot or an endoscope, you can do a quick discectomy in 20 minutes or even less for people like Sukumar Sura to do an endoscopic microdiscectomy. So technology has really helped not only in the scar size, but also in the speed, blood loss, safety, and so many other things. So it's very important that we learn about this technology, because the technology is far advancing. What you have today in next 6 months is outdated. In next 5 years is totally outdated, and something new is coming up. And that is how people who've been for 20, 30 years in spine surgery who have seen this. So today what we're going to focus on different surgeries using this technology to see how that technology is helpful, what it does, what are the benefits, what are the pitfalls. Technology always comes with pitfalls, and there is a learning curve. Each one has a different learning curve. So that is what we are going to focus, and that is what the spine bootcamp is. I sincerely thank everyone from the bottom of my heart for being here to share their knowledge. And without much delay, I would like to invite our first speaker, Dr. Bharath Dave, who's going to talk about ultrasonic bone scalpel or curator during the surgeries that he uses. Off to you, sir. I'll just switch off, and you can share now. So after each talk, we will take a few questions, and we will keep the talks to about 15 minutes each, so that we have time for about 5 minutes of discussion.
Good evening, friends and faculty, seniors and colleagues. I'm going to talk about the ultrasonic bone scalpel and safety in the spine surgery because of the bone scalpel. Thanks the Spine Bootcamp team to give me opportunity to share my experience and to share my views. These are my disclosures. So impressive to see this happening. And we do come across OMG situation, oh my God situation. That's what I'm going to share you a few examples. And how can we tackle this situation? And how can we tame the Murphy, as Dr. Vishal told in his introductory talk. So this is one of the case, 72-year female, male, paraplegic, 2 years, since 2 years, and C56 was the main lesion. But he had multi-level fluorotic spine. Another one with the OPLL, you can see the 45 gentleman with spastic quadriparesis with the disc spared, but there was significant big OPLL. Another one with the giant thoracic disc, as you can see here, and that is something which is seen there as well. So how can you tackle this situation? And what is the safe instrument which we can have in order to tackle such high-end cases? And that the safe instrument in my book or in our book at Xavier is surgery, which is done with the bone scalpel, neither burr nor osteotomy nor nibbler. And that is UBS, ultrasonic bone scalpel. And that gives precision and safety. How does it work? Well, it works, let's say ultrasonic ultrasound frequency, which gets converted into the cutting by the piezoelectric. So, the handpiece, it has got the piezo crystals and it converts that into 22,500 times per second. So that is something which is to remember. Yeah. So that is something which is and it has got the irrigation tube. So it has got kind of handpiece, which is piezo crystal, and it has got this and will go into the console of the bone scalpel, and it has got the movement which comes to and through, it doesn't cut like that. It cuts, it likes a vibration, and which is 22,500 cycle per second. So that is how it cuts the bone. Now this is you must remember this and you must see this and watch this. This 7 is the one with the frequency. 100% is the pulse. So if you keep it 100%, it will cut all the time. If you keep it 80-10 or 80-20, then it will have kind of, it will have the pulse cutting. And the flow, when you are operating the fluorotic case, then you should use the 100% flow. Otherwise, you can keep it around 70% flow. This you can increase and decrease depending upon the bone density. So if you increase it to 10, that will have the more and more stronger cutting edge. So this is must. This green button, it enables the console and the handpiece which you are going to cut. So we must charge the whole tube, irrigation tube, in order to, and the irrigation tube passes from here in order to have it functioning properly. So if it is charged, then it is the water irrigates through that tube. If the water does not come, then it will generate a lot of heat and it will burn the tissue. So make sure that before enabling, we charge, we make sure that the water is coming, not like the prostate patient, like the usual gentleman, the young guys coming out from the thing. So this is just to make it a little bit okay. It has got the ultrasonic blade, which is from different size, 10 millimeter to 25 millimeter. It has got the diamond shaver, as you can see here. It has got a diamond shaver, and it has got a diamond shaver, and it has got the micro hook shaver as well. So I have few videos which will show you how to use the micro hook shaver as well, and the bone scalpel. Primarily, the advantage is perioperative outcome are very good, particularly neurological deficits and the dural tear. At Savia, we are using this since last nearly 9 years plus, and we have now three console, and that's what has given the strength to the surgical outcome as well. Secondarily, it reduces the operative morbidity, it reduces the blood loss, it reduces the operating time as mentioned by Dr. Bala, and certainly that way it reduces the hospital stay as well. Does it cut the hard tissue only? Yes, it cuts the hard tissue, but if you stay for more than a second, it can burn the dura as well. So you need to keep moving it from one end to other end, or the cut that you have made, you need to keep moving that as well. Otherwise, it will cut the soft tissue too, or it will burn the soft tissue. So this is how it may push the soft tissue if it is not adherent. So this is also worth knowing as well. So it has got tissue selectivity, but not specificity. I would say, it can cut or it can burn the dura as well. Conventional method, one can have the Carison used, but one should not put the compromised canal, the Carison as well, because the foot plate of the Carison itself can compress further neurological structure as well, neural manipulation, and that is what can lead to 20% deficit. So that is where the advantage of the bone scalpel comes as well. If you look at this video, so we are using from either end, one side is the bone scalpel and another side is the burr. And one can operate that as well, and one can do, such surgery as well. But that is something which can be used, and both the surgeon should be well versed with the technology. So comparison with the other bone removing technique, if you look at the bone scalpel dissector, it has excellent bone dissection. It has got excellent precision. It has got tip displacement is negligible, and the hand fatigue is negligible unless you end up with operating onto the fluorotic patient. While all other techniques like Carison, osteotome, or high-speed burr, it has got lot of bleeding, fatigue, and it has got the bone dissection. You cannot really do the bone dissection as well. You can burr the bone, but you cannot dissect the bone. Like if you have to take the bone graft, then you can take the bone graft with the bone scalpel. So the bone scalpel, it has got kind of outer table, inner, middle, and the inner table. So it has got, each one has got a different way of handling as well. And this is something which this picture shows, that how we should make the cut first, and then we go in deep and then come out, deep and come out, deep and come out. And then last inner table, we should cut it at the end with more precision and with more accuracy as well. Like the osteotome, it will separate, but this one decays the bone. It eats the bone, I would say, in other words. So outer cortex, less axial pressure, more side to side. Middle cancellous bone, axial pressure with slight with slide side to side. And for the inner cortex, controlled axial pressure with frequent side-to-side movement that will reduce the damage to the neural structure. And less thermal injury is observed if you follow this particular rule. So coming to the first three cases which I had shown, these just showing you the pre-operative, and this was something which was done.
I repeat on that. That will help in outcome. Agree.
So you can see the bone scalpel is used to cut the dorsal. It is dorsal laminectomy. And we are fortunate to have three consoles, so we can operate from two ends. One starts from the middle and one starts from the cranial end. And then we end up operating or doing like the first case, which we did, C2 to D12 laminectomy in 2 hours. And what we do, we mark the cranial and caudal end, and then we gradually lift the lamina. And if the dura is adherent, we do the durotomy. So that will not pull the whole cord. And once it is done, we check the inner side of the lamina so that the most compressive element, whether we have removed that or not, that gets confirmed as well. Now, if you have to cut the sidewise, this is the most important thing. One can do that as well. So this bone scalpel can remove the small piece of the bone which was left behind by the central cut. Similarly, the side which is quite projecting onto the cord, that can be done with the hockey stick or rather the shaver. As you can see here, the shaver is used. And gradually it decays the bone, and you can see that it is very well done, and that part of the bone is removed. And in any case, if the dura is adherent to that bone, we usually do the planned durotomy, and we cover it with the G patch. So that's been removed, as you can see. Similarly, we can do corpectomy as well. So we do the discectomy first, and then at the uncovertebral joint, we identify and we do the corpectomy one after another. We always make sure that there is no double dura sign where the dura will be adherent to the OPLL. So by using this osteotome, we make sure that the bone and the vertebral body is detached from the either end, and then we lift it up, and you can see that we have removed the bone and corpectomy is complete, and this bone can be used as a bone graft. This is the cervical laminectomy. We have done the laminectomy in order not to have the C5 palsy. So we go little bit medial to the spinal laminar line in order not to have the cord falling back completely. It will certainly fall back because otherwise the patient will not recover. And the lamina is detached from both the end. and it's being lifted, and we see the pedicles, rather the lamina, and we count how many we needed to remove, and then we complete the procedure. Another one, that is dorsal discectomy. So here we have put the screws and we do the pars excision. Once the pars excision done, then we have the cord which is visible, and as you can see, the pars is excised. This is a dorsal disc case, big calcified disc, and you can see the cord which is in front of us, and we do not retract, neither we touch the cord. Discectomy is done, and the trough is made, disc is removed, the opposite side rod is put so that the spinal column becomes stable while doing the discectomy. And then the calcified fragment is pushed in the cavity which is created by the bone scalpel. So these are the C2 to D12 laminectomy, as you can see, and this is the postoperative MRI of the same patient. This is the corpectomy which was done, double level corpectomy, and this is the discectomy which was done. So similarly, this case again, you can see we managed to do the laminectomy as well. This Ponti's osteotomy can be done with the bone scalpel as well. That will give good correction. Extended utility with the O-arm and navigation. This has been one of the case where we have already published as well, ventral sculpting. And you can see that there was this internal gibbus, and which has been removed with the bone scalpel, and the bone scalpel was with the third party navigation it was used. So you can actually see where the tip of the bone scalpel is going. And that is what we managed to do the sculpting. And you can see that this is the diagrammatic figure, and we managed to do the case pretty well. As you can see in the post-operative MRI here, you can see the cord very well relaxed as well. And patient had paraparesis. So that was one other case, where we really have to be very careful. So coming to the last few slides, Cavitron ultrasonic aspirator is a surgical device which leads to cavitation, and it is used for the tumor target tissue, and it irrigates the area with the sterile saline. We have few publications which, if anyone want to read, go through it. So it was a tandem stenosis cases, thoracic spinal stenosis, and we were able to conclude that it is a safer alternative. It reduces the hospital stay, blood loss, and the advantage technology. Ventral sculpting, the case which I have shown you. Ultrasonic bone scalpel corpectomy, this was published in the European Spine Journal as well. This was another one which we published for the scalpel for the cervical laminectomy. And the most difficult one is this side effect. And this is worth knowing for each one who is going to use this, because the water jet is pumped with some fluid, some air bubbles as well. And that leads to pneumocephalus. And the pneumocephalus can be as bad as, when we have not yet to open the cranium, but it can be very bad, and it can displace the whole brain as well. So this is worth knowing. If somebody complains of a lot of headache, it is not just CSF leak, but it could be pneumocephalus. And transforaminal interbody thoracic disc, which I have shown you, but that's one published as well in the Global Spine Journal as well. So in conclusion, ultrasonic bone scalpel is better than the other bone dissecting devices. It reduces the operating time. It reduces the blood loss, practically nil, I would say, particularly for the corpectomies. It does not twist or push the bone surface. There is reducing incidence of the dural trauma. All this factor reduces the hospital stay, readmission rate, economic burden to the patient. And I will call this as a miracle gadget. Many of such ultrasonic bone scalpels are available for the use. One can try whatever best suits to your hand, and particularly some of the hand pieces are little bulky, some of them they are small, but it is worth putting and investing in our operation theater. Thank you for your patience hearing. Thank you. Thank you for giving me the opportunity.
Thank you, sir. That was really an amazing demonstration of this gadget. It looked so easy and smooth. But shall we get some questions? If any of the audience have one or two questions.
Please unmute and ask. So if I may I?
Yeah, please go ahead.
Very, very nice talk, sir. And in fact, I am irritated by, I'm more and more lured to buy this system. But my biggest question is it so safe that it really doesn't hurt the dura at all, even when axial pressure is applied? Or it is
Yes.
still, you still have to control your axial pressures on it?
So no, I think one thing which is very important when you do the cervical laminectomy in the OPLL cases, what we often do is to restrict our inner cortex, and we do not really cut the inner cortex on in many cases when the cervical OPLL is extending right up to the lateral border. And in such cases, we just sort of connect the inner cortex, but it is safe. Vishal, we have 3 of it now. So it just shows, the workload and, the passion. It is not just the passion, it is just the safety, which we have, got with the bone scalpel.
So just taking it forward, sir, what were the problems with a conventional drill or a diamond burr tip that you faced in the conventional drill burr tip that made you to shift your hands to the Mesonics or ultrasonic cutters?
If you drop your burr, what will happen? If you have real good control of the scalpel, the burr can go anywhere. If you just, you have to concentrate, or anywhere you have to concentrate, but your burr can damage a lot of things. That is one. Bone preservation is 2. And third thing is the blood loss. These 3 things have given us, it has led us to use the bone scalpel.
Right. Arvind, since you are here, and Amit Jhala, sir, since you guys are here, have you been facing challenges with the bone burr tip? Because we are going to have bone models with burr drill workshop also. We are going to have Mesonics real-time workshop also in spine boot camp. And those are real-time workshops. Apart from the machine, there will be hands-on experience of these. Have you been facing a problem with the drill burr? Arvind first and Amit second, sir. Jhala, sir.
Yeah, so I've used this Mesonics once. It's a very good instrument, but somehow I'm a bit scared to use it. I don't have that perception of depth with this Mesonics. I don't know when the inner cortex gets cut, and so actually the patient did very well. That is another thing altogether. It's just the fact that I've been very, very comfortable with the burr, and probably I have stable hands, and I concentrate a lot on the burr, so I've not had any mishaps as till now. But it is a very good instrument. Probably, when there's a long segment to be done next time, I probably use a Mesonics.
Yeah. So the message is that the axial pressure has to be controlled. The second cortex should not be cut through, particularly in OPLL cases. And also, blood loss is lesser with these instruments. And the pressure, I was seeing the digital numbers that Dr. Bharath was mentioning, that if you really want to cut through the whole thing, you can change the numbers from 7 to 10, which determines the power of the radiation of that thing. And the water flow also has to be controlled to keep it meager. I think this will all come in hands on. Dr. Amit, your experience with Mesonics and your experience with drill burr.
Yeah, so I would absolutely echo with whatever Dr. Bharath has told, that I am also a big fan of the ultrasonic bone cutter, which I use it. I don't use it in open in very selected cases, but I also use it for all my MIS over the top and the other cases also, because I have very sleek the cutter, which is not a Mesonics one, which is of other company, but it really helps in doing it safe and faster, both the things together, I would say.
Yeah.
So especially in OPLL, OIL, there is no doubt that it has a role, but also in MIS, I use it in and out. So I am very echoing the same thing.
Saves the parts, ne, Amit bhai. It saves the
Yes,
parts.
yes. No, no, it is a very precise cut. So you know exactly what you want to cut. And it's like a knife. I would say it's like if you want to cut a butter with a knife, this is the way that it will cut. So I am
That
very
brings you a question from the delegate. Are these also applicable in endoscopic approaches?
yes, yes. It is also applicable. Supposing I am doing it in UBE. So in UBE, if you want to use it, it's a fluid medium. So water is
It has
there.
got a long hand option. It has got an angled option as well.
Yeah.
And for Dr. Arvind, you do get the giveaway feeling as well when you cut at the end. That's where you need to stop and withdraw.
Yeah.
I
Dr.
mean,
Bharath, one question from delegate.
experience.
Dr. Mukesh wanted to know, how often do you change the tip of the scalpel? And are there any tips of preventing the handle heating up?
Yes, handle won't heat up. If it heats up, there is something wrong with the piezo crystal. So handle won't heat up. That is one. Second thing, we practically are now able to use it in 5 to 7 cases. One tip. So we autoclave it and we keep using it. So we have about 6 hand pieces. So we keep them ready. But then you can use it in 7 cases.
Yeah. So before you go, Dr. Bharath, thank you so much over here. But there are so many questions coming up for you from the delegates on the chat bot. Before you go, please, if you can for us reply each question in detail on the chat box while we shift on to Dr. Arvind. Bala, over to you to introduce and welcome Dr. Arvind Kulkarni.
Hi.
Thank you.
Thank you, Dr. Dave. It was a really inspiring talk for the young people who want to take up this technology. Now I invite Arvind Kulkarni. He doesn't need much introduction. He's one of the stalwarts in Mumbai, and a well-known minimally invasive surgeon, founder member, and executive secretary of MISAB, and so many other things. Arvind, please, we're just listening to hear about navigation technology.
Yeah, first of all, I thank Vishal and Bala for this kind invitation. So I'll not waste much time. I'll go to the presentation straight away. This is a young patient who came with neck pain. To give a clue, he had nocturnal neck pain, which got better with NSAIDs. So we suspected an osteoma, which was missed at many places because neck pain patients are very common and you tend to ignore. And rightfully, he had this osteoma at the superior end plate of C6, quite posteriorly, very close to the cord. And conventional wisdom would be to do a discectomy at C5-6, do a partial corpectomy of C6, excise the lesion, and do an anterior recon with a large cage and plates. There's nothing unusual about this particular suggestion. Which in a current situation of where there's a momentum for motion preservation surgery could be called a satisfactory answer. So with increasing interest in minimal access, motion preservation surgery, especially this lesion involving the C5-6 disc, which is the most mobile disc that we have, and this guy has a long reserve of almost 50-60 productive years in the future. We thought of doing something which is slightly out of the box, not being for the sake of being out of the box, just to preserve motion at that particular level. So we thought of excising the lesion without damaging that particular motion segment. Rightfully, navigation was handy. So we're using navigation we used a surgical precision. It was a surgical strike. We could go and pull out the lesion without any collateral damage to the adjoining disc, the cord, or the vertebra. So this is the upper slides are immediate post-op, and you can see very well how the bone has been reformed in that track that was left out. And just like, that's a navigation is like, helps you to become as precise as Arjuna's aim, that is the eye of the bird. So this turned out to be an osteoma. And this we published. You can see the patient's disc is intact at the end of 1 year. He has mobility at C5-6 with no previous pain. So that is the advantage of minimal access. Another similar patient, he had this was a very deep-seated lesion in the pedicle of right S1, that he had this osteoma. If not for navigation, how would you excise this lesion in getting it right in XYZ planes? So that is where navigation helped us. I'll talk about these various instruments that we're using later in the slides. This is the monitor, those were the diodes. This is called the tracker, which helps in tracking the anatomy of the patient in response with respect to the saved anatomy on the stealth machine. So we could localize the location as well as the depth of the osteoma. And this is an example of a terrific combination of minimal access with navigation. So you can verify where you are on the patient. So the real image and the virtual image can be merged to get your to get your outcomes. So you can see so this is a navigated drill. So what is done through the tube is seen on the screen. So that is a nidus probably of the osteoma. Sorry. So you can rerun this intra-op CT to check if the lesion is out. So that is what was done. So the osteoma is out, and that's the beauty of the procedure. So MI surgeries are focus surgeries, and our goals are, because these are focal goals, these are focal pathologies that need to be sorted. So if it's an open surgery, we depend on surface marking. Since it is minimal access, there is a huge dependence on images. So here necessity is the mother of investment. So initially we used to do all these TLIFs with fluoroscopy using Shyam. So these are the various steps of a minimally invasive TLIF as an example. So every step was checked on a Shyam. So we did succeed in doing all these procedures using various advanced armamentarium. Since they were all image guided, we ended up taking almost close to somewhere between 50 to 90 shoots for a single level TLIF. Imagine what it would be for a 2-level or a 3-level surgery. So the surgeries were all successful. We did difficult cases with increasing experience. Presented them at various various levels, published at various podiums, only to realize that we are burning ourselves out with radiation. So radiation is a big risk, as we all know. Along with that, these are all Shyam dependent surgeries. So it is dependent to the Shyam machine as well as the technician. You might end up having a poor image if the patient is obese. You will end up having poor images if the Shyam is of poor quality. If the technician is not trained, You'll end up with misplaced implants, doing wrong level exposures, and when you get poor quality images, you increase the number of shoots that you take, that increase the doses of radiation, ultimately leading to bad consequences. Again, it is a Siam based image, so you get it in 2 dimensions. So you don't get the axial dimension. So here you see a patient on top where the screws look okay on the X-ray, but the medial screw, the right-sided screw at L4 is medial. Again, this is a patient who developed RSD post TLIF because the screw tip was anterior. So axial plane is something which is not seen on a Siam. Again, these pedicles can sometimes be very curvy. They can trick you. They could be narrow. They could be misshapen. They could be asymmetric. So you get foxed sometimes. Again, there are reports that at the end of a surgery, the surgical drape along the Siam, it has 100% chance of contamination. So these are all the worries which push you to use a navigation. So navigation is basically using a virtual image and integrate it with your real anatomy of the patient to guide your instrumentation and to guide your various steps of surgeries. So how does navigation work? Basically, you get the patient's images using an intra-op CT or a pre-op CT, and that you register against the patient's real anatomy when the patient is lying on table. And this is done with through various advanced instrumentation. So one is the navigation system with the monitor, that is a stealth machine. Second is the localizer. This is the camera. I'll talk about all this. I'll show you in terms of pictures as to how these are used. Then you need that software which integrates the patient's anatomy and the patient's anatomy with the image that you got from the CT images and the patient's reference frame. This helps in communicating the real image versus with the collected image on the CT scan. And these are various instruments that can be sensitized to this navigation. They can be located in 3-dimensional space to be used on the patient. And this is the imaging of the patient. So what you do is basically you take the CT images of the patient, preferably intraoperatively. And then once the patient is lying on the table prone, so you take the CT images, and these CT images get incorporated into the stealth machine, and then you fix the patient. An anatomical part of the patient is fixed with this reference frame that has LED emitting diodes. So these are the LED emitting diodes, and this is called dynamic reference area or a patient reference array. So this communicates with this, camera. So this entire process helps in integrating the images that are caught on the stealth machine with the real anatomy of the patient. And these diodes can be fixed to all the instrumentation that you are using, like the tap, the screwdriver, the cage holder, any instrument that even an osteotomy, any instrument that you want to use during surgery can be sensitized to this navigation. So that is in simple words. For example, here I'm trying to put pedicle screws at C2. Now the first step is after getting the CT images incorporated into the stealth machine to put a clamp. This is the array, and this has diodes connected to it. And the instrument is similarly sensitized using the LEDs mounted on it. So this way they communicate with the camera. So the real image of the patient gets integrated with the CT images that we have procured initially. So that helps in inserting your tap, inserting your screw, etc. So for example, this will make it simple. So this is
The video demonstrates a case of minimally invasive navigated TLIF.
Is it audible, Bala?
Case of L5S1 spondylolisthesis.
We can hear. Thank you.
It's a mobile lytic listhesis. The patient is positioned prone under general anesthesia. Tracker is applied to one of the spinous processes of the upper lumbar vertebra. The isocentric C-arm takes a spin around the patient and delivers CT images which are merged to the navigation console. Navigable Jemshini needles are used to make entry into the L5 and S1 pedicles, both sides, and guide wires are passed through the cannula of the Jemshini, and these guide wires are anchored to the patient's ribs. Navigable taps are used to make tracks for the pedicle screws. Special reduction screws are used in this situation. They are passed into the L5 and S1 pedicles on the opposite side of the symptoms, that is, on the contralateral side of the symptoms. Now, on the ipsilateral side of the symptoms, a series of dilators of increasing diameter are passed in the intermuscular plane to create a temporary portal on a final tubular retractor is docked the trajectory of the L5S1 disc, which is verified with the navigation probe. A vertical osteotomy of the left-sided L5 inferior facet is performed. These are the usual steps of a TLIF procedure. Following this, a horizontal osteotomy of the left-sided S1 facet is performed. This is the window of opportunity through which a discectomy is performed. Following the facetectomy, a laminectomy procedure on the ipsilateral is performed. This is basically to identify the tubular sac and the exiting nerve root. Remember, spondylolysis, it is the exiting that gets trapped underneath the fibrous cartilage of the defective pars interarticularis. So it is necessary to isolate the exiting L5 root and then identify the disc space. When the disc space is identified, a box annulotomy of the L5S1 disc is performed using a series of various instruments like the discectomy forceps, the shaver, and the curette. The discectomy is done. In the case of degenerative spondylolysis, there is stenosis circumferentially. So one needs to do a thorough decompression, which is done by angulating the tube on ipsi and contralateral sides. You saw the amount of bone graft that was harvested by using the lamina and the facets. So the disc space is prepared using disc cutters, various sizes of shavers. Now we go back to the contralateral side where using an interesting mechanism, the rod is passed and the listhesis is reduced. This mechanism is called the sextant mechanism. It's a very interesting way of measuring the rod size using the principle of opposite angles. The rod is attached to the sextant and the rod sits on the tulips of the S1 and L5 screws on the opposite side. Initially, the S1 pedicle screw is fastened with the inner nut, holding the rod in between, following which, using a special reduction maneuver, as you see here, the L5 screw is pulled up gradually. That can be witnessed in the Siam. This particular mechanism, spondylolysis is reduced Now we come back to the ipsilateral side, that is on the side of the symptoms. After doing the cage trial, anterior one-third of the disc space is packed with locally harvested bone graft. It's called the sentinel bone graft, followed by impaction of the cage of the right size. So then you can see these screws being driven into the ipsilateral S1 and L5 pedic. These are the
So that is how you can
most of
actually see the
images,
screws.
and this is the final end product.
So there's something called near total navigation. Each and every step of surgery is done without using a C-arm. So you can see the depth of your decompression. You can see the ipsilateral corner of the traversing route. You can see the depth at which your cage is gone inside. You can basically verify the degree of decompression that you've done. So you can see how far anterior is the annulus, how far the posterior is the annulus. You can measure the size of the cage, depth of the sentinel graft that you impacted. So all that can be done. The only step where you need to check is when you put the screws in. So this is almost near total MI surgery. So it is said that to be a successful surgeon, you need the eye of a hawk, the heart of a lion, and the hands of a lady. I think the navigation makes up for the eye of the hawk. So this is a patient with degenerative scoliosis with a very good example wherein you can do a selective decompression fusion. There's only one level which is involved, and it's very badly rotated. And these are the cases where navigation plays a big role. So using navigation, we could easily insert our screws without scratching our head. Again, in a situation where there's poor anatomy, so it looks like a charcoal factory of Dhanbad. So you hardly see the pedicle entry point here. In such situations, navigation is a big role to show the trajectory entry point as well as the trajectory of your pedicle screw. Again, in revision dimensions, trajectory to realize the anatomy which might have got interfered with previous surgery becomes very easy with navigation. So again, should we be totally dependent on navigation? So such mishaps happen. Man is far from infallible. In such situations, navigation has a big role. Again, this is a case where there was a degen scoli with isolated stenosis at one particular level. So again, the trajectory and the angle at which you work can be difficult. So we use navigated drill here because of extreme convexity and concavity and orientation issues. In such situations, navigation has a role. You know where to stop, you know how much to decompress, you know the plane at which you're working without doing a compromised decompression and without creating instability. In situations like this where where you're fixing fractures, you're doing multi-level fixations. Here it is a big role because you can otherwise, if you're using CM, you should be loaded with radiation. In difficult deformities such as this hemivertebra where we use navigation. In craniovertebral areas where if you want to put a cervical pedicle screw, for example, so that is where navigation helps. So there are various applications of navigations. So benefits of MIS are, well established. Radiation is a major concern. So navigation is a big role in MIS. So it is a blessing. It helps as a blessing in minimizing radiation contamination. It minimizes revision surgeries. It is a blessing in optimizing precision. You can put a screw in the right trajectory. You can put it the biggest screw that is necessary to get the best fixation possible. So overall, it makes the surgery safe. It reduces the operating time, and I think one should inculcate and incorporate navigation in their practice. If their practice is loaded with is exposed to a lot of where there's exposure to a lot of radiation, and if they're doing a lot of MIS surgeries where anatomy is absolutely blind because you're working on a surface, so navigation is a big role. Thank you.
Thanks very much, Arvind. That was a really nice, comprehensive discussion about use of navigation. A couple of questions we will take. Can you tell me your experience when you started off from using conventional X-rays into navigation, where you have this feeling? Because I have a lot of juniors ask me, I'm not sure if I've placed my screws absolutely right, and they want to take an X-ray. Or they put the cage and then they want to know how far the cage is, what is the position in AP lateral. So how do you have the transition when somebody is in the learning curve where you want to see that, okay, do you take an X-ray, or how did you change?
Yeah, so initially you always have that fright, as to where your screw is gone, where your cage is gone, how deep has it gone? Has it gone into the abdomen? So the first few cases you should not be a slave to navigation. You should be the master. So you shouldn't get carried away. You should always check, like the way you check how your fellows are doing, whether they're sincere or not. Similarly, you need to check whether your navigation is sincere to you or not. So initial few cases, you need to verify with Shyam. Shyam is your best friend at the end of it. Though it gives you radiation, Shyam is your best friend. So you verify with your best friend in the first few cases. Once you're sure, then probably you can start being dependent on it.
Yeah, there's a question from Dr. Srinivas. Will there be a difference pre-op CT supine and intra-op CT prone?
Yeah, don't use a pre-op CT, especially with navigation. So it is exposed to errors because the position of the patient when he's prone on the table is totally different from when it is supine. And initially we tried to use pre-op CT, and we never could match the anatomical landmarks with the virtual images.
Perfect. Yeah. So there's no more questions. I'm sure if you are staying for a few minutes, you can answer it if anybody puts a question in the chat box. But thank you so much, Arvind, for being here and sharing your experience, extensive experience of doing complex work as well with navigation. Thank you so much.
Thank you.
Thank you. Now we'll move on to our next speaker. Do we have Dr. Amit Jhala there? Sorry.
Dr. Chhabra's talk is
Dr.
first.
Chhabra, yes. Dr. Chhabra, yes.
Yeah.
Hi, Dr. Chhabra. Thank you so much.
Hi. Thanks, Amit,
Being here,
for
Dr.
pointing that
Chhabra.
out. Yeah. Right. So I was talked to share our experience on robotics in spine surgery, and I'll try to explain this simply, but I also have a video, so do let me know if the audio plays with it. If not,
Sure, sir.
what to do. So, from conventional, we moved on to navigation. That was a big step forward. And then as technology advances, there's the option of robotic surgery. And for both, the pros are that you improve precision, have smaller incisions, shorter operative time, less exposure to radiation, quicker recovery time, reduced risk of complications, and lower risks of revision surgeries. And this is well documented in the literature, as we'll discuss subsequently. So the indications would be, at the moment, wherever you need fixation, but then the indications are gradually evolving, and hopefully one day it would be also used to assess the adequacy of decompression, planning osteotomies, and a lot more things than what it is doing right now. All this is already in the pipeline. So, see, the biggest challenge is putting in implants in a deformed spine. And there are enough studies to show a very high rate of accuracy with robotics in a deformed spine as well. And uh, studies to show reduced radiation substantially compared to navigation and CR both, reduced complication rates, reoperations, and average length of stay. So this is a video. Just let me know if you can't hear the audio.
Sure. At the moment, we can't hear any audio.
Sorry, let me just check then. Any tips on how to get the audio going? Can you hear it now?
Sir, if you know, we can't hear now. So if you just click on the audio, next to it, there's a little arrow mark. Then
Okay,
it'll
okay.
ask you to select.
Let me do that. So
Next
what
to
do we
audio,
select?
arrow mark.
Yeah, what do we select on that?
So select a speaker. So your microphone is your input, and your output, if you select your laptop, there's a name of your laptop like Mac.
MacBook Pro speakers, right? So can you hear now? Bala?
No, sir. Can't hear right now. Or if you click audio setting, if you go to the same thing and just click audio setting,
Yeah.
and in the output, it must be selected your automatically adjust microphone.
Okay, no issues. I will let the video play and I will talk simultaneously.
Sure.
No issues. Just a minute. So this is a 16-year-old female and presented with a progressive deformity. So cosmetic issues were also a concern. You can see a kyphoscoliotic deformity. So it was 50 degree of kyphosis. These are the CT scans. And the reconstruction images show the L2 residual body, right? There was no pod anomaly per se. So you use either an Allen or a Mackay table. It needs to be radiolucent, and the robo is attached on the side rails and the stealth navigation on the other side. So this is mainly because we need to use OARM seamlessly throughout the procedure. And then, of course, you use neuromonitoring for this. So it is multimodal monitoring. So this was an open surgery. We exposed the area. So you attach the robo to the patient through a posterior superior iliac spine pin. So the robo will define the safe area for movement. This is called 3D define, right? There are optical cameras which help it. Then you have a snapshot camera for robotic registration. And then you mark the area of operation. This is a star tracker. So this will help in the intraoperative cone beam CT. You can see the OARM there. Images are transferred and you see that the star marker is found. You mark the areas of interest of vertebral column in AP and lateral views. So these are the images of the OARM on which you mark them. Auto segmentation takes place and you may need to manually improvise it. and they are registered in the independent disc spaces. The vertebrae are marked and labeled, and you then correct, especially in deformity cases, in all three planes, the axis is corrected, and then you plan the screws, right? The system will allow you to choose different size and size of the implants. So we have to plan such that skiving potential is minimum. So you can see in submillimetric CT cuts if the screw is appropriate or not. And you see in all three planes, axial, sagittal, and coronal planes as well. So that you are sure that screw is in the right trajectory. So similarly, you do that in the other level, right? So you can adjust the size of the screw. In this one, we increased it to 6.5 mm. So we are correcting the trajectory on the sagittal plane in this view, so that it's not directed towards the end plate, right? So you can see a high soft tissue pressure also if it is there, right? We smoothen the entry point in order to reduce the chance of skiving. So you smoothen the bone at the entry point. So wherever you direct the robo, like this, it is at the T12 pedicle screw left side. The navigation probe you'll be able to see the direction of the screw. You tap this sleeve so that it engages on the bone. That will prevent skiving, right? We add saline to prevent thermal injuries, and we use the navigated high-speed drill, right? That is very important. And you can see on the navigation the direction in which you are going. So the principles remain the same: sound and check the pedicle walls, right? And then once it is confirmed, then you can put in the pedicle screws. You can see that the self-tapping screw is going over the desired trajectory that you have planned on the robo. So now you can see it going on the other side. Cannula sleeve, mallet the sleeve, add saline, drill the trajectory, drill, withdraw the drill, tap, and then you put in the pedicle screw. And everything under navigation visualization. See here, you could see the cannula getting skived, and you readjust that, right? If it is under vision. So you can see every time the same sequence is repeated of drilling and tapping. So now this is the non-robotic part. We proceed with the laminectomy for the correction of this kyphotic deformity. You have the rod on one side, and then you put in Harrington gauze on the lateral and anterior side of the body, and then put in a spoon retractor, lateral and in front of the body. So it would retract and act also as a protection sleeve. So while you do the corpectomy, you can have a circumferential view of the cord. So we are removing the vertebral body here. We can use the burr also, other than the osteotome. So with the using the osteotome, we can harvest the bone, which can be used as a bone graft subsequently, right? So the bar is being used to remove the remaining part of the vertebral body. The bar is also navigated, so you can check the edges of the corpectomy, and you can plan the corpectomy accordingly. So then you put the final contoured rod on one side, because that's the advantage of using reduction screws. Remove the rod from the other side and complete the corpectomy. So we are removing the pars and the pedicle on the opposite side. Then we complete the corpectomy on the other side. We insert bone graft using the, and then we are compressing to correct the kyphosis. In this case, we could have bone-on-bone correction, and that's why we didn't need to put in any cage. And you can see that the correction was achieved. So we've been able to achieve good correction of the deformity here. Neuromonitoring was intact, and then we prepared by shingling for a better fusion, and then closed as per the routine procedure. So this is the pre-op and the post-op image of the patient, and the correction well done. So we could achieve 20 degree of lordosis in this patient, right? So, sorry. So just want to share some tips and tricks on robotic spine surgery before would want to take any questions. It is very important to have a meticulous focus on the OR setup. And I say, as I mentioned, you have to have a radiolucent table, and you mount the robo on the table on one side, and you have the navigation as you see on the head end, and the robotic monitor on one side per se. There is a monitor or a surgeon's console also with the robo, where the surgeon can himself control everything and decide on the workflow which works best and adhere to it meticulously. So there are two workflows. One is a scan and plan workflow, where you use an O-arm during the surgery, and the other is a CT fluoro workflow, wherein you plan on a pre-operative CT scan. And here the advantage is that you can plan before, a day before or 2 days before, over a cup of coffee in a relaxed atmosphere, and then all you need to do is execute that in the operation theater. Then, as I told you, we need to attach the robo to the patient so that they move as one unit if there's any movement. And for that, you put a PSIS pin, but there are clear-cut guidelines. For an open, in a PSIS pin, you can go only up to L4. For a MIS surgery, it can be used up to L1. Above that, spinous process clamps are used. You can see the spinous process clamps on the side here. And you have also Shan's pins and other types of transfixation pins. But we have now started using pins in the pedicle also as we go up in the higher up in the thoracic spine and also in the cervical spine. Now, it is important that if you put too much movement, like if you put too much movement during the incision or during screw insertion or during drilling, then you may violate the O-arm position that you have taken, and that may lead to errors. So it is best to have a feather touch for all the movements that you make here. So even drilling, you use a high-speed Midas Rex system drill, and it is important that you start the drill before you enter into the bone, and then you withdraw it also accordingly, so that there is minimum movement that is there of the patient per se. We have to ensure throughout that there are stable fixation points for the clamp, the bone mount, and the dynamic reference, because during the procedure, if you are using a spinous process clamp and if you impinge upon it, it may move, and though an alarm will come on the robo if there has been a movement, but you will need to go through the registration process again. So it's best to avoid that. And also, while taking the O-arm scan, you have to ensure that ventilation associated excursion of the thoracic spine is minimized. You ask to the anesthetist to have the patient in non-mechanical ventilation mode as you take the image per se. And here you can see if there is too much of a soft tissue pressure expected, then there is an alert which comes just to let you know that you need to be cautious. And this is a high power drill which is used and which has significantly. So you can see if you use a normal drill, there are more chances of skiving. Whereas if you use a high speed drill, there are less chances. You can see here that it will go directly into the bone and the chances of skiving reduce substantially. So the take home message, robotic assisted spine surgery as per current evidence may be more efficient, and safer for pedicle screw instrumentation compared to navigation or fluoroscopic assisted freehand approaches. There is level one evidence is required to increase the statistical power of these conclusions. Right now, we have a level 3 evidence in this regard. The major limitation in widespread adoption of robos may be the associated cost, but we need to look into the cost-benefit analysis rather than just the costs. Future generations of robots have immense potential to improve spine surgery for both patients and providers alike. We may be able to mold the rods and do a lot more things. There would be automatic planning. You may be able to use the MRI in the planning rather than the CT scan. So what we witness today may be the building steps to the definition of routine spine surgery in the future. And it's important that we start understanding the robo. As the robo understands us, this may be the key to achieve optimum results. Thank you for your patience. And I'll be happy to take any questions if there are.
Thank you, sir. Thank you so much. That was a very elaborate discussion for the robot. I'm just looking for any questions in the chat box. There aren't any at the moment. But Dr. Jhala, you want to ask a question?
No.
No. Okay. Dr. Chhabra, just a couple of questions which because there's a lot of young people here and also watching on the OrthoTV. Is a dream for any spine surgeon to have a robot. There's just a handful of them in the country. The learning curve, how long do you think it took you or your team to do how many cases, how many pedicle screws before you became comfortable?
So I'll first let you know the literature. The literature says anything between 0 to 50 cases is the learning curve. But I feel that if we need to be safe with the robo, it takes at least 100 screw insertions, because you need to learn the skill to prevent skiving and you need to be well versed with that. And that is an art that you need to master and which comes gradually. Nowadays, literature is available. When we started, there was not much literature also available for robotic use. But anywhere between, say, around 100 pedicle screw insertions would be the minimum before you can say that you have learned the trick well.
And also, for example, the one that you have is a Mizorex. And do you have to only use Medtronic screws, or can you use, and how does that work?
See, the process remains the same. After you have drilled, you can put in a wire and then put in any screw there subsequently. So we have used Indian screws, all sorts of screws. The only thing is that they would not be navigated. You won't be able to see them on the navigation. But you have to be sure that you are putting the screw in the right trajectory, because skiving can also happen while putting in the screw and you may be totally off track. So you ensure that you are sticking to the trajectory, and then you can use any screw per se.
Sure. Yeah. Thank you so much for your time. Thank you for being
My
here.
pleasure. My pleasure.
Thank you, sir. Thank you so much.
Thank you.
Move on to our next speaker, and may I invite Dr. Amit Jhala to talk about something that he's a super expert in, OLIF lateral position surgery, where he's going to demonstrate to us about how position a patient for a lateral surgery, and he's going to show all the armamentarium that we are going to be seeing that he uses for his surgery. Thank you, sir.
Thank you, Dr. Bala. First of all, thank you very much for inviting me to present on this topic. As you say that I'm not going to talk much on the indications and when to use this approach or nothing like that. But I'm just going to, if anybody wants to start this procedure, then what are the things which are required, how it can be done. So I'm just going to look at all these parts rather than going into the indications and all that things. So if you know that this is going to be my lecture plan, it's going to be a principle of lateral lumbar interbody fusion. That's first thing I'm going to talk. And in this, I think cage has a lot of importance. I'm going to talk about a little bit of cage because that's a basic for the oblique lumbar interbody fusion. Approach, a little bit of approach, because then only you will know what instruments which are required. If you know the approach, then what instruments are required. I'm going to talk about the checklist before the procedure, what all the things that you should have before you start the procedure. What are the special instruments which are required for LLIF? There are certain technology which has come in for LLIF, and you may like to use them. So that I'm going to talk, and you can do the same procedure with navigation and how it helps. So this is what is going to be my lecture plan. So if you see, you know that oblique lumbar interbody fusion is an anterior interbody fusion. It is a retroperitoneal approach. So you have to go through the abdomen retroperitoneally, and you approach to the disc space between the aorta and the anterior margin of the psoas as shown here. And therefore, there is no issue of damaging the lumbar plexus, and then we don't use the neuromonitoring for this procedure. And why you should use this procedure? So it is more of a physiological approach. And the physiological approach, because if usually we use it for spondylolisthesis where there is an instability along with the lumbar canal stenosis. And this is the picture. If you see a spondylolisthesis, then you have a ligamentum flavum buckling with loss of disc height. You have a ligamentum flavum hypertrophy because of the dynamic effect of the on the ligamentum flavum, and because of the loss of alignment, you get a static compression. So this is the basic pathophysiology why the stenosis occurs in spondylolisthesis. So how it works? So you insert a large spacer or a cage inside, and once you insert a large spacer or cage inside, there is a stabilization of the spine, there is a jacking of the disc space, there is a ligamentotaxis effect on the PLL and all the surrounding ligaments, which reverses the buckling of the ligamentum flavum. It aligns the spine, gives indirect decompression, and of course, you have an added advantage of having a larger surface area for the fusion. This can be achieved by a lateral lumbar interbody fusion, either by OLIF or an XLIF. I am much more in favor of an OLIF because of obvious reasons, because you don't go through the psoas muscle. So this is a picture that if you see, this is a patient who had a zero disc space or very less disc space with a grade 1 listhesis and a stenosis. And once you put in the large size case, you can see how the foramen is reconstructed, how you can get a disc height, and even the alignment is reconstructed. And you can get a very good, even overall alignment of the spine. So this just putting the cage, we have not done any decompression or nothing is to be done. And this is therefore I say it's a more of a physiological approach without disturbing any of the anatomical structures, actually reconstructing the whole spine. And that's the big advantage of this approach compared to the other. So this is again in an animated view that you see that this is vertebra and this is a stenosis which is there. So there is a central stenosis, there is a lateral canal stenosis, there is a facetal hypertrophy, there is a reduced disc weight. These are the osteophytes. And if you see this, and if you just put a lordotic cage, and the main important part of this cage is that this cage goes anterior to the fulcrum. And when it goes anterior to the fulcrum and you jack it up, you can get a good central and lateral canal decompression along with a lordosis or a sagittal alignment. That's very, very important if you want to do it at multiple levels. So that's the big concept of this thing. And you see, this is one of our patient who had a double level. I'm just showing the video of the single level. You can see that how just by putting, this is the wire going there, and this is the wire, and then you can see you remove the disc and you put in the sizers, and after putting the sizers, you put in the cage, and you can see how the whole thing has aligned gradually from grade 1 listhesis to a normal, even in a calcified type of the disc which was there in this patient. So that's the big advantage of this procedure. Now, compared to the TLIF and PLIF procedures, this has an advantage because these cages are more centrally located within the cancellous surface, even whether you go for TLIF oblique cage or a banana cage or a bilateral PLIF type of a cage. And because they are in the cancellous region, there's a chance of subsidence and there's a less lordosis, which has been very well proven in the literature if you do a TLIF compared to the lateral fusions because you are going more anterior. So the concept of the cage is big advantage. The cage goes from one end plate to the another end plate, which is filled with the bone graft. So it's a very large cage. And that's why you get indirect decompression. Goes from end plate to end plate. So it has a very strong, with very large surface area. And because of that, there is less chance of subsidence. You get a better disc height, better lordosis, and good sagittal alignment. So that's the big advantage of this cage. So this is one of our patients where had Shiza's grade 3 type of compression. You can see there. And this is a post-op, immediate post-op MRI. And you can get a good disc height. You can see a very nice decompression, which is there in both the planes, sagittal as well as in the axial planes. So this was an immediate post-op of the patient. But now we have got a follow-up of more than 6 or 8 years. So this is one other patient, and this is what we have already presented in the that was published also, and this is presented in the Spine Week Australia. And you can see this is a grade D type of stenosis. This is immediate post-op, and you can see that we get a 93.9% increase in the overall canal diameter. But if you see that a 24 or 2 months follow-up, you get nearly normal reconstructed canal with just a cage. So Shiza's grade D was converted, and you can see the thinning of the ligamentum flavum, which was there. And you can see that grade D is converted to grade A. So it's a normal spine which you reconstruct over the time. So you get an immediate decompression, immediate clinical relief, but over the time you can get a nearly normal type of the spinal canal. So that's a big advantage. For the approach, you see that you have to go through the abdomen and between the major vessels and the psoas muscle. So with this concept, if you want to do this surgery, I think these are the things which are very, very important and essential if you want to do this surgery. So first thing is you have to have a preoperative investigations and informed consent because you are doing an indirect decompression. It's very important that you should also inform that we are doing indirect decompressions. In around 8 or 9% of patients, it can fail. Though this is a recent literature, my experience is quite different than what the literature has told. and preoperative investigation of actually watching the MRI and whether the corridor is there or not. It's very, very important. And that's why this checklist is very important before even you select this as your procedure. You require definitely C-arm. There is no doubt about it. Initially, I would suggest that nothing has to be blind. You require either microscope or loops. You require a headlight because you are working in a deep cavity. And sometimes in an obese patient, it's very difficult to see inside with the tabletop lights. So headlight is definitely advantage. You require the implants. You require some general instruments, which I'm going to talk later. You require a bone graft set, and you require anesthesia equipments and catheter. Catheter is also must because you are going near the ureter. So it's better that if you have a catheter, you may have initial cases. If you have a catheter, that will give you some guideline if there is an injury to the ureter or not. So these are the things for the checklist which are required. What are the equipment checklists that you require? You require a special instruments for an OLIF, like dilators for the tubular retractor. You require a tubular retractor set with different size blades, flexible arm to hold the retractor. You require retractor holding pins. They are all there along with the set of the OLIF of whatever company that you use. You require shavers, sizers, cage holder with end plate protectors, different sizes of cage extraction device. It's also very, very important because sometimes you may be in a wrong place and you want to extract the cage. There are specialized spine instruments which are required, which also you might have to procure, or they come with the certain companies set, like kerosene punch, which are long bayoneted kerosene punch, disc forceps. You require long dura retractor. You require a backslap hammer to remove the cage in case it is required. Long curettes, Cobb's elevator. Cobb's elevator is very important because you have to go to the opposite side to remove the annulus. You require angled curettes. You require long suction tips. So these are the equipments which are very, very important for this. In OR requirement, OR setup, you see there are a lot of gadgets which are there. So unless you have these gadgets which are in the proper place, sometimes we will have a lot of issues. So the surgeon is usually on the abdominal side of the patient. So you require a C-arm coming from exactly opposite side. The microscope comes from the opposite side, from the head end, and the imaging processor comes from the foot end. The rest, this area is for the instrumentation and the scrub nurse. So this is the setup that you have to check whenever you want to do this procedure. So this is our setup that we use. So this is the C-arm, this is the lateral abdominal edge, and then that's the monitor, that's the microscope which is coming there. So this is the setup of which is required, or the positioning of the patient and all that. It's very important to have the table requirements and table, because this procedure is totally under fluoroscopy. So before even you start your surgery, you require that you should have a radiolucent tabletop, and you should check the fluoro pictures before you start this procedure. So that's very important that you have a radiolucent tabletop. You require an adequate post to fix the patient. That means you have a pelvic post, and you require two posts on the back. So that will make the patient stable. But even after that, you require straps. There are three straps which are very important. One is a shoulder strap, one is the pelvic strap, and there has to be a strap at the foot end here, so that you can tilt the table during the surgery whenever it is required. So these two straps are also important. Sometimes we have to strap sometimes the abdomen, because sometimes if the abdomen is bulky, you may not be able to see very nicely the AP views. And sometimes this strap also is very important to pull the belly. It's very important that there are different tables designs, and these table rails should be able to take the retractor, the flexi arm, which can be attached to the table. So these rails have to be checked, because unless you have these fixed rails, you will not be able to attach this flexi arm there. And it has to be having added paddings and tapes. That's what I say. Now, because it's a deep abdominal approach, you see that you start from one side, and with the help of the finger, you go to the psoas, and then you go to this area. It's a deep abdominal approach. And therefore, you require all these general instruments. It's not a routine spine instruments that you have. You require these instruments, and I'll just name that you require all these retractors, even with the big levers which are required, because if the patient is quite bulky, then these retractors might be small enough. So you require a full retractor set, and that's the very, very important part. You require a vascular forceps because sometimes there are veins which are there at that area. So you require a vascular forceps. You require a peanut or a swabon holder to swipe the peritoneum from the or the abdominal contents. You require a long hemostat, or sometimes you require a mixture also. The other thing required is a long cautery. These cautery pencils also require a very long. So you don't think that the general instrument set is going to work. So you have to have a long cautery pencil along with a long bipolar forceps. If there is a bleeding there, you have to control that bleeding. You require a bayoneted long knife handle also. So, and different types of mastoid retractor. So these are very, very important things if you want to start this surgery. Then these things which are very, very important to have with you. Now, the other very important thing for the OLIF is the orthogonal maneuver. So when you dock in the retractor, you are in oblique position. And if you just travel in the same position, you will hit the foramen, or sometimes you may hit the opposite canal. So every time you enter into the disc space, you will have to make it more vertical and parallel to the disc. So this maneuver is known as orthogonal maneuver. So any instrument which goes through the tubular retractor, you have to use it once it enters into the disc space in an orthogonal maneuver. So it's a disc prep instruments, or whether it's a trailing instruments or trialing instruments, or it can be the implant. So anything, you should have this orthogonal maneuver, which is one of the key points for the OLIF procedure. Otherwise, you will damage, and you may go to the foramen and damage the dura. So because you want this orthogonal maneuver, this retractor has to have an opening there. So if this retractor does not have an opening, you will not be able to do this type of a maneuver. So you have a retractor blades which can be expandable. So the expandable retractor, unless you have an expandable retractor, you will not be able to do this maneuver, and therefore it's very, very important. So the specialized instruments what are required is the expandable retractor. So this is the expandable retractor, and there are different sizes of the blades which are there for the expandable retractor, starting from around 60 to around 140 or 120 in some cases. So these are the different sizes which are for the right and the left, like this on the right and the left, which are attached depending on the size that you get. So there are two holes also here, and this is for the retractor pin, which I'll show in the video. So these retractor pins will go inside the vertebral body. And then this will, if you just open this with the help of this screwing device, then this retractor will open. But if these are the flanges, if you push this, it will open in the same diameter on the outside, but inside your working area will increase. So this is an angulation. So if you press this, these blades will also angle. So it will open also, and it will angulate also. So that's why you can increase your working area. Supposing you want to do a corpectomy, then this is helpful because you cannot expand it much. So you have to expand it less and then work inside for the whole corpectomy. So these are the sets which are very, very important thing. The other thing, these are the routine shavers. These are the Cobb's elevator. This is the sizer. So they come in different sizes, and you have to check that they are available for different sizes. This is a cage holder, but this cage holder, if you put the cage directly there and you put the graft is going to spill. So you just don't use this cage holder alone. This cage holder has to have come with the end plate protector. So these are the end plate protector, and this you have to tie along with these. You have to tie it with the vicryl so that this end plate protector also does not open up. So this is very important instrument to put in the cage. And of course, with that, you require a long carisons and long disc forceps. So these are the specialized instruments which are very, very important. That's the whole set. You require the long carisons and disc forceps. You require the dilators. You require the flexiarm. You require sizers, shavers, Cobbs, different types of curettes to prepare the end plates, even the long suction tips. So these are all the instruments which are required. So with this, so what I'm going to share about is how it is used per op. I'm not going to show the whole video. because I'm not interested in showing you the whole video. The main part is how it is used. So once the approach is done and you have reached your fat, and you have reached up to the finger dissect anterior 1/3. So this is what it is. And so once you have reached at the desired disc space level, then you dock in the first dilator there. You put in the wire, guide wire, and that guide wire has to go inside the disc space. And once it goes inside the disc space, you hammer. Guide wires are very notorious. You hammer the first dilator inside the disc space and remove the guide wire, because we don't want guide wire, it can go anywhere. Then you remove the guide wire, and over the guide wire, you use the different size of dilators, diameters of dilators. And then you check that your dilators are at the particular position, which is in the anterior 1/3 of the disc space, anterior 1/3, 2/3 of the disc space. And then you put in your tubular retractor. There is a marker on the dilators, and that will give the size, that which size of the blade is required. And this is the pin which goes there, and that will fix. So this dilator will be fixed, this retractor will be fixed with the pin also, and this is how it expands. So you just have that will also expand. And then you remove the dilators. Keep the first dilator inside, so that this is a microscopic picture. So you know that this is the anterior border of the psoas, and then you do a thorough annulotomy. Okay, so for this you require a good long blade. Okay, then only you can do this annulotomy, and then you do a discectomy there. The thing is, now you see what I'm doing is I'm putting this inside and then doing the orthogonal maneuver, and that's where you require this slit, which is very important. If this sizer goes, it goes obliquely. You can see here it goes obliquely, but once it enters, I am doing an orthogonal maneuver, and that's why that's very, very important step to do. Okay, so that's the orthogonal maneuver there. So with any instruments that you put inside, you require the orthogonal maneuver. This is even the Cobb's elevator, which goes for the opposite annulus we need to break. So that goes to the opposite side, but that also goes in the orthogonal maneuver. So that breaks the opposite annulus. So this, and then you check under image also that this is. Then these are the sizers. These are the sizers. It has a mark anterior and posterior because these are lordotic cages. So it has a 6 degrees, 12 degrees cages. So you have to check that anterior has to be anterior, and the sizer, then you can adequately size whatever gradually increasing sizers, and you find out what fits best to the patient. So these are the sizers which are there. And you can check that it is very nice. Then this is a cage. And this cage, you can see there is an end plate protector. That end plate protector will not allow the graft to spill. Again, you put it inside the disc space around 1/3, and then you do this orthogonal maneuver, which is very important even in, otherwise the cage will not be in the right position. Okay, so this is what the procedure is. Then you do a final check, and that's the post-op X-ray of the patient, and this was a pre-op of the same patient. So these are the technological, and these are the smaller things which are very, very important. Now, there are certain technological variations which are there. This was from one of the companies, but you can get different type of retractors. So this was a Myers original report retractor, which had simple Langenbach had a Steinman pin which could go. And that is how it was used. Then there was a frame retractor which came. Even it has been reported by Myers et al. This was by Sylvester, and then he used the simple Steinman pins, and you can see these 2 Steinman pins going, and in minimally invasive, just putting into the vertebral bodies, it could retract and they could do the procedure. But with advancements, this is for the DeLift retractor by Pimenta, and you have this 3-blade retractor. So from 2-blade retractor, which I showed you, there are companies which are having now 3-blade retractors. So 2 retractors will have the expansion, and third will also retract the abdominal fat, which sometimes comes in the way. So that is a third retractor. And this is also, so this is a 2-blade Medtronic's retractor, and you have a Globus 3-blade retractor. So either of these things you can use it. Three blade has an advantage because you can retract the abdominal fat also, so that it does not come in the way. Okay. So sometimes some surgeons don't like any of the retractors. They just want a handheld retractors, and you can do the same procedure with the handheld retractors. But then you will have to have these specialized retractors, which you can hold it with your hand and do the same procedure. Okay. Now, this is a three-blade retractor, which has an advantage, as I said, that it's an advantage. It's a very versatile. So it can open, this blade will retract the abdomen, or it may retract the fat. And this too expands, and you can get a very wide field for working area. And this blade also can have an angulation on both the sides. So it's an angulation also, you can get it. So this has a three-blade retractor, which is also very, very cool. And we do it for delay, for OLIF, whatever. And then it has also got a two-blade option and three-blade option with a 22 millimeter internal diameter. So 22 is usually that we use for the OLIF. Then it has again the same shin or the pins which can go inside and dock on the vertebral body. And the last thing is, because they are all radiolucent, then you can see that in the C-arm that it does not come in the way. So these are the different retractors that come. There are certain cages which also I need to speak, because mostly we use the PIC cage, but then there is a resurfacing or PIC with the titanium resurfacing which has a more stability, and there is a bone ingrowth, and therefore the fusion gets better. So 3D printed cages are also coming up, and 3D printed cage have more porosity. And because of the porosity, the fusion is faster and stronger. You can have an anatomical 3D printed, which is a box type. You can fill the graft inside, but then it is completely sealed from top and bottom. But there is a bone which grows through and through. So that's a porosity. And sometimes if you want to do an anterior fixation, it also comes with the plate. So these are the varieties of the cage that you can get for the lateral lumbar interbody fusion. One of the varieties is the expanding cage. That means it is very small when it is around 7 millimeter, and it opens to around 15 millimeter or 14 millimeters. So that's an expandable cages. And if you have a very less disc height, then these cages are very helpful and useful if you want to use them. So you can do this procedure. What I showed was in a fluoroscopy, but then in fluoroscopy you require to have a change of the position from lateral position to the prone position for putting the screws. But you can do it if you have a navigation. You can do it with all thing with a single position. So this is a case that again the same patient. We are all doing simultaneous single position OLIF also, because we have a navigation and O-arm. So patient is positioned in laterally. There is some change because the patient is not on the abdominal side. We keep it in the center, and we turn the table oblique for insertion of the wires. Otherwise, it's difficult to put in the wires. So we turn the table, and because of the navigation, there is no problem of putting the wires. You can see the patient is in the center of the table rather than the abdominal side. And the O-arm comes here. So that's the anterior part, that's the posterior part. So O-arm comes from the foot end. And then you can take and check this thing. The insertion of the pelvic pin for registration should be at the PSIS. Then get the O-arm pin, and we can work two teams together. That means this is the pelvic pin. And once you have, this will also be navigated, and you can also navigate the abdominal part. So both the things can be navigated, and you can work faster without changing the position. So even if you want to put the incision, if this pin is there, you can just put the first dilator, and you can check that exact level in all the three planes that you are at the exact level, and then even mark your incision for docking accordingly. Then once that is taken, we take the approach from anterior. The first dilator is guided inside the disc space, all through navigation. You stop at this point because you don't want expansion of the disc. Then you put in your all percutaneous screws and the wires inside. That is what we do. And then put in the screws also. So we navigate all the screws in in the lateral position also. We measure, then we come into the front, we measure the disc height. You can even measure what amount of length of the cage that is required with the help of the navigation. And then you put, you totally clear of the disc space. These are the trials and sizes. You can see that you are absolutely orthogonal. You can even find out from this what length of the cage that is required. And that's the final picture where the cage is actually going and the cage insertion. So you have an accuracy of the cage, adequate orthogonal maneuver, and you prevent the, and you can get the best length of the cage. And that's the final cage position of these patients. And that's the final 3D CT picture of the patient. So take home is that the lateral fusion requires not only the technique, but a lot of technology, specialized general instrumentation, specialized OLIF set, specialized retractors, specialized cages, more precision and perfection with navigation. But you have to have a laparotomy set for any complications for vascular as well as for the abdominal complications, because that also has to be there in your standby. Thank you very much. And any questions?
Thank you, Dr. Amit. I think this is the most lucid talk that I've ever heard on OLIF, because it brings in right from the beginning of what exactly is needed for a beginner to start OLIF cages or OLIF procedures, right from the positioning equipments to instrumentation to armamentarium to retractors to disc prep sets. And it really highlights the zest of spine boot camp, that you really have to master the instruments and armamentarium before you think of doing a surgery properly. Otherwise, you are going to struggle and hate that particular surgery. Thank you so much for bringing out this talk, Dr. Amit. Wonderful. I really enjoyed it.
Yes, yes, I should say that it's a really a pleasure to listen to that, and it gives you the whole perspective of, how it can be a very simple procedure, but also if you have a very obese patient with not the right gadgets, not the right maneuvers, you do it, it can become a very complicated procedure because it's not something that everybody does. And for the young people, Dr. Jhala, I just want to ask you, for the young surgeons who are here, how do they go about learning to do an OLIF? Just in simple words, what kind of cadaveric courses they have to do, learn the instruments, because most of them are not used to doing abdominal surgery. They're not used to seeing peritoneum. They're not used to retroperitoneal approach. What would you say for
Absolutely. So I think unless they do not one, but many courses of cadavers, and whenever they go to the cadaver, whenever even I go for the cadaver workshop for them, I absolutely open everything and show all the anatomy. Unless you have, you should not have a focused anatomy. You see, OLIF is a focused anatomy. So if you just do a focused workshop of putting the retractor and doing the whole procedure, that's not going to help. So once you have done the procedure, I would advise them to open it up, see exactly the whole anatomy, where all the structures are, how far or how much distance is the major vessel, where is the ureter, where is the so these things are very important. So multiple workshops are the only way, because I know that as on today, the retroperitoneal open approaches are very, very, very less. So there is no point learning peroperatively. You have to learn only in the cadaver. So that's the first thing, and then go to the mentor who is doing it and watch it. So that's the only thing.
Sure, sir. Thank you. Thank you so much. There's a lot of appreciation for your talk. Thank you, sir. And now I'll invite Sukumar Sura, who's going to talk to us about endoscopic procedures, and he'll focus again on the various, the techniques and the skills that are required in terms of endoscope. I also, just before he starts talking, I want to say that during our spine boot camp, we have 2 robots from Brain Lab and Medtronic. We have 3 navigations from Brain Lab, Medtronic, and Stryker. So we have about 5 companies who are coming up with their drill systems. So you'll be able to see the different companies, what variations they have as well, in terms of the instruments, in terms of the technology. And also endoscope, we have a few companies who are coming with their endoscopes. Sukumar, all yours. Thank you so much.
Yeah. Hi, I'm just sharing the in.
Sukumar, when do you take rest?
He doesn't.
So I think we should organize a session of lullaby for Sukumar. He at least gets to sleep well before he really teaches us.
So, good evening, everyone, and thanks, Bala, who is a brain child behind this boot camp, and Vishal for organizing this pre-conference, pre-boot camp, rather, spine workshop. So, my talk is very simple. Here, all are talking about the technique and technology. The theme of this today's talks are technology before technique. So just go through a simple endoscopy, what we are using, the small tips, what a young endoscopic spine surgeon need to learn. So we know all the limitations, whatever we are practicing today. To definitely we have some limitations, and we use these simple technologies. It's not complex. We've been using for many years in other fields, and we are just modified for past 5 to 6 years. There's a lot of adding technology and finish to the existing technology, and we are able to do it today. So I'll just go through the OT.
Kumar, can I just interrupt? Can you make it full screen? Just click play
Player. Okay, 1 minute.
on the top. Next
Yeah.
year.
Yeah,
Next
got it.
Yes, perfect. Thank you. Sorry to interrupt.
Yeah. So just give me a second. So just OT setup is very simple, as we do for any spine surgery. You need a simple OT table which we use regularly for our spine cases. There is always a debate about whether to do some remove the lordosis of a patient while operating a simple disc or a stenosis. So definitely, when you break the table and just make the lordosis go away, you do increase the interlaminar space, and it helps for discectomy. But some are against doing that in cases of stenosis, where you might get a false hope that you have done a good decompression. So it is up to the surgeon how comfortable it is, but I always break the table, and CM, definitely you should have a good CM, and I always suggest people having a good the C, the distance, the diameter of the C should be more, so that when you are operating, it should not have any problem. So this is the monitor which we use. Monitor setup should be such that you should have a good HD monitor, where the size is not important here. You can size is okay, the 36-inch monitor or a 55-inch monitor. But when you have a big monitor, you definitely get a benefit. And this is the usual setup. We'll have a camera, light source. These are the two integral part of your system. Then you will have a radio frequency machine, and a drill machine, and a irrigation pump, which plus or minus it is up to you to use irrigation pump or not. So this is a basic setup you use for a and I just go through the simple instruments. What all instruments should be kept ready before you start your day. So it's this is a simple access instruments, what we call a dilator, a sheath, and the small rongers, the punches, the annular cutter straight. This is a Kerrison punch kind of a thing. We call it a stoop sheath punch, and a simple dissector. And this is a miller, where we can mill the tough tissue, and this is an annulotome. So these are 6-7 instruments which are to be kept ready, and tell your sister that you keep this aside. So once these things are ready, then you check the other things. The checklist is very important for a beginner, because when you start an endoscopic surgery and you promised patient endoscopic surgery, suddenly your things are not sterile, then you will land up in trouble. So always have a checklist, have things checked before a surgery as a beginner. So this is a autoclaved or either ETO or plasma sterilized camera and the scope. I always use either plasma or ETO. All my the drill system, scopes, and all the cables go to the plasma, and all the metallic equipment or instruments we do autoclave. So there is no concept of inserting these equipment in Sidex or what to say, per se or Sidex. They are very dangerous. The particulate or the chemical, if you don't wash properly, they might develop severe chemical discitis, which a patient will have post-op. So I have stopped doing this very long time now. I either do plasma sterilization or I do what you say, ETO. So this is the setup you have. This is 6 to 7 instruments. They are very simple instruments. There is no complex instrument required in endoscopy. And this was the position I was talking about. Position always a little bit, we break the table so that the interlaminar distance is more, so that as a beginner, you find the space there to work around your anatomy. So setup when you are on the left side and when you are on the right side, it differs. So when you are on the left side, this is the setup I use. Shyam, which will be in situ in lateral position. To my right, sister will be standing. This is the way I stand. So Shyam is in situ. It's in lateral position, and sister stands adjacent to you because being a right-handed, taking instrument in your right hand is always ergonomic. And I stand straight like this towards the monitor. So this helps me not having a back issues or a knee issues or a neck issues. So for a surgeon, the position is very important. And I give my foot pedals to my assistant. Other than drill, I give either to my colleague or a fellow or sister takes the foot pedal of monopolar and radio frequency. I keep the drill. So ergonomic way of working if you're on the left side. If you're on the right side, you can see here the sister goes to your right and she stands at the head end. And the previous image, you see the monitor is at the leg end. And when you are on the left side, when you are on the right side, the monitor goes to the head end. So as a right-hand person, most of the surgeons, so this arrangement is more ergonomic and helps you not having a back problem or a shoulder problem. So the basic instruments, the important of all is the scope. So this scope again, whatever company you use, so this has an angle. So this has a 25 degrees, 15 degrees, 12 degrees, and 20 degrees angle, and it has a working channel all in one. Working channel, irrigation port, and the light source. All three are in one scope, and so it's called uniportal, and camera is attached. So this is a uniportal wet irrigation or wet endoscopy, what we call. There's so much of terminology is confusion. Some call it as full endoscopy, some call it as endoscopy, some call it as uniportal endoscopy. So there's a lot of terminology confusion, but better we use a full endoscopy because everything is done with the same tube. And as I was talking about the angle, so angle adds to the armamentarium. Already you are magnifying and clearing the field with the saline. The angle helps you create more field of vision. The slightest angle and the tilt of the scope will give you the doubles the field of vision. So that's why a 0 degree compared to a 20 degree, there is a significant increase in the field of view. So just to show the difference, this video is taken to show the difference between the 15-degree scope and a 20-degree scope. Or how does it discuss about the angle of the scope? So this is a 15-degree scope. It's a 15-degree scope. You see here is a 15-degree scope, and this is a sheet. So 15-degree scope goes in a sheet where the bevel is small. The same thing when I'm using a 20-degree scope. This is a 5 degrees more than this. This is a 20-degree scope. And you see the bevel. See the bevel when compared to a 15-degree, when compared to a 15-degree. And so when you compare the scope as the degree decreases, the bevel has to decrease because it has to accommodate to the angle. And if you are working with a more angled scope, your bevel increases as a result of which the area of the field of view also increases. And the important point is when you are having a bigger bevel, here I can open the punch better. I can open the punch better. You can see here, so because the bevel is bigger here, I can open the punch better. I can come here and work within the cannula. I can work within the cannula because the bevel is bigger. So you can see the opening here. I can open bigger. I can open bigger. I can open bigger when cannula scope is still inside. I can open the punch bigger. Same thing if I try here. The same thing when I try here, because your bevel is small, and when I am working, the scope is inside. When I work here, I cannot open more. You can see here, I cannot open more. I cannot open more because the bevel is small. The opening will be small. I cannot work there. That's one disadvantage. Then we'll go and see intraoperatively how does this bevel and the angle helps us further. So you can see this is the 15-degree bevel and the 20-degree bevel. So definitely the field of vision increases in 20-degree scope. And coming to the next is the important tool in endoscopy, the mandatory tool is the radio frequency. So when you are talking about radio frequency, we all use the bipolar and monopolar electrocautery in day-to-day spine surgeries. This just image shows that on the left side it's a monopolar, on the right side it's a bipolar mechanism. So when you are using monopolar, there is a lot of energy transfer into the tissues, causing significant tissue damage and also the collateral damage. The bipolar mechanism, what does it do is the current is focused and focal, and the tissue energy transfer is very, very less. And when you compare the radio frequency over electrocautery, I'll just come to that in a minute. So the common we use the radio frequency probe we use is 4 megahertz. So how does it differ from electrocautery or the bipolar cautery we use in our day-to-day practice? So the bipolar, what we use in our day-to-day practice, it is in around 400 to 500 kilohertz, and the radio frequency we use is 3 to 4 megahertz. So it is almost 10 to 8 to 10 times higher frequency we operate in endoscopy. How does that help? The effect is very focal. The effect is focal. The tissue spread the damage is very, very less. So as a result of which we are under irrigation. So the 1/5 the effect on the tissues ultimately becomes 1/5 of the whatever cautery if we use without irrigation. Here I'm using a coagulation here. So how do I teach here? To go to the 12 o'clock, I have to just press it. It opens up at 12. I want to go at 6, I just have to rotate it just goes to 6 o'clock. For 3 o'clock, I just rotate, and for 9 o'clock, I rotate top position. So you need not rotate my wrist. You can see here, I'm just rotating the handle here. So I can go all around 360 degree without touching here, the probe when I push. So usually the settings which we keep are around 20-20 for coagulation, coagulation and cutting. That is enough. Some people keep 30, and ultimately when you want to shrink more, they keep 40. So what has happened beyond 20? The coating around the bipolar probe goes away. The insulation goes away, and you start losing the insulation, and it becomes less effective because the spread of current becomes more. And in next cases, when you want to do a focal coagulation, you can't do it. So the probe usability, where if you use it carefully, we can use it for 8 to 10 cases. If you are not using, you are using more power, then you just end up in using for at least 2 to 3 cases. So to prevent this, try to one is the usability of the probe, second is the damage to the neural tissue. So better is either use 20 or maybe less than that, it is safe. And radio frequency again versus lot of people use today plasma radio frequency. Everyone asks me what is the difference. So radio frequency, as we all discussed, radio frequency works in megahertz. So the difference between RF and the plasma RF are the radio frequency is a conventional. It creates a thermal energy, and it desiccates the tissue and ablates it. But whereas in plasma, there is a lot of ionization. The radicals ionize and they become vapor. So as a result of which, the plasma radio frequency is more aggressive, more effective, and they claim that it is less penetrative, so that the tissue damage is less as they claim. But I am not sure because before I've used it before, some patients had paresthesias post-op. I thought the energy is more in plasma than radio frequency. So I use only radio frequency, but not plasma. But plasma is good for bone bleeding. It is very, very effective to stop the bone bleeding. The next important tool we use is the drill. So the drill system is the one which has changed the perspective of spine endoscopy. With the drill coming into the picture, we are doing more and more cases. Spectrum has increased, especially elderly stenosis and fusion. With this drill has become very easy. So what is the important difference between an open drill system and endoscopic drill system is this one. So in endoscopic drill system, it has a very, very high torque. The torque is very high, but speed is low. Speed should be low. We can increase the speed, but speed should be low. Because when you increase the speed, there is a vacuum phenomena created around the burr, and it sucks in the tissue. And so when you are inside working in a 4 to 5 millimeter space in a uniportal surgery, when you have a more speed, what happens is tissue comes in your burr, and every time you have to clear it, and you can't see what you are doing or what you are drilling, and it is not safe. So low speed is enough, and if it is a high torque machine or a motor, then definitely the low speed will help and can do wonders. And you can do most of your job with low speed setting somewhere between 3000 to 10,000 RPM. So second, how to use it. So because endoscope is a long tube and your bit is very long compared to open surgery or other surgeries, so definitely you need to use it wisely, otherwise you will break. So you can see we are using the drill here. You can see the handle is long and how it should be done. I'm resting my wrist against the camera here. I'm using it. I use it as one unit. I don't bend this one. So my left hand moves. Left hand is for movement all around. Left hand moves entire unit. Right hand is only for cranial depth, zoom in, zoom out, or what you can say, take the diamond bit deeper or come out. So superficial and deep movements are with the right hand, left hand is all for the movements. It's all this movements is very important to left hand. Everything should move as a one unit. So this is very important, otherwise you'll break the bits and the usability of bits becomes too costly. So the second important point when you are using a burr is what type of burr you are using. So you can see here the first the So there are three kind of burrs we use. One is a sharp cutting burr with a hood. One is a diamond burr, and the third one is the cutting burr. So each has its own uses. One the burr which we use is just the video is not running properly. I'll just start with this. Okay, so the usage is always you use the burr sidewards. So you don't use the burr anteroposteriorly. Use always the burr sideways. So only the side part cuts, and you can see the front part of the burr doesn't cut here. So that's burr is designed in such a way that it is not drilling here. It is not drilling here. So only use the side part of the burr, so that you don't plunge inside. Always use the side part of the burr. You can see here it is not cutting here. So that's the advantage. Only use the side part of the burr where you can always protect the deeper tissues. And go bit by bit, don't be in a hurry, because here if you do you rush here, you might lose the vision and you might plunge and cause devastating injuries, as is with any other open surgery. So the other bit we use is the diamond drill. So where again diamond drill, the advantage is that we can use the side of the burr and also the front of the burr. So diamond has more control because of the granularity of the diamond. The grip is better. You can see we saw the front of the burr was not drilling. Here I can drill with the front of the burr and the other side of the burr. So we can use both ways. And a diamond burr is very good to control bone bleeding. Sometimes bone bleeding decreases your vision. So diamond burr helps you doing that fine work. The other important burr is to make our work faster is this burr, which is oval burr with a hood. So what does this hood do? It protects the tissue coming in your way and has a two parts. So you can drill with either the tip or with the belly of the burr. So when you're using the tip of the burr, you can do a focus work. You can see the tip of the burr here, and it's a hood protecting it. The tip of the burr, when you use, you can do a focal work and a pointed work. When you use the belly of the burr, we can do it very faster. So, and our RPM would be around 3,000 to 6,000 here. So no need for a more RPM here. There is no wobbling here, because when your torque is good, you have a good motor, it doesn't wobble at all. You can see I use the tip of the burr. Now I use the belly of the burr. When you want to things to be done faster, you can use the belly of the burr so that it cuts the faster, and it doesn't plunge because you are only using the side of the burr. So your work is always outwards. So there is no plunging here. This is a very important tool in endoscopic spine surgery. And next thing is the irrigation system. Again, because the saline irrigation is the one which has changed the perspective of endoscopy. So it's a wet endoscopy. So either you can use a gravity, which is well enough. Most of the time you can do it. You just have to have a theater which has a good height, so that you can keep on increasing the height. all the Japanese surgeons, they believe in only gravity and they do only under gravity. So Germans use a fluid pump. So I use a fluid pump because the fluid pump helps me increasing and decreasing the fluid pressure as and when required when I am doing during surgery. So for any to begin with, I am extra canalicular. I am outside the spinal canal. I use somewhere between 40 to 60. If I enter the canal, I'll be using around 40 to 50. If I need some pressure, I just increase it to 60 to 80, then again come back to 40 to 60. So 40 to 60, most of your work is done in between 40 to 60. Don't go beyond MAP. Whatever you keep asking your anesthetist, what is the MAP, mean arterial pressure? Don't go beyond mean arterial pressure so that you should cause some serious trouble. And the second important thing is what pump you are using and what scope you are using. So there are no smart pumps in the market where you have very good sensors. So sensor-based pumps which senses the intracanalicular or where the working area and it auto-adjusts the pressure. So those are the ones which are very helpful for a beginner to have a good field. So this video is just to show what is the difference between when you're using a irrigation pump or high pressure with gravity. What happens when you're doing when you're using such things? So you see on the left side, this is a scope which is oval in shape, and the sheath is circular. What happens here? The saline seeps out very easily. Even when you are working through the working channel, saline is continuously coming out between the scope and the sheath because it is oval and circular sheath, oval scope. But when you see the other one, the circle, the second one, you see here, what happens here is it is a circular sheath with a circular scope. So it is watertight there. The water doesn't leak there. It leaks only through the working channel. And the side which is there, two tubes are there here on the side. So, but when you put a instrument inside, it becomes watertight. When you put an instrument inside, it becomes watertight, and you might have a problem here because it becomes watertight and pressure builds up, and patient can have a severe neck pain or neck related issues causing serious trouble. So always use a good outflow mechanism, and when you are not using this outflow mechanism, then be very wise and don't increase the fluid pressure.
Sukumar, can
So
you,
this is what
finish, please?
last 3 steps.
Sure. Thank
So
you.
this is just to just close the my talk. This is a simple case illustration, very simple, that we did this last month. A case with a D23 severe radicular pain, and we went paraspinal here and went into the disc, and you can see the descending facet, ascending facet, and rib head nicely delineated here. Once it has to be drilled, once it is drilled, you go to it is drilled like this, go there, drill. Because of this vision and the small tube, we can do these wonders where in open surgery, we might end up in doing a 2-level or 3-level decompression and doing fixation. So this is the end point. You can see with a small stitch, we're able to do a complete decompression. Left side of the patient. This is the last slide. Central and paracentral. Sorry, just if I might have taken time. So that's the decompression endpoints. Thank you.
Thank you. Thank you so much, Sukumar. Sorry, I had to ask you to rush. I think it's very.
We are running.
Sukumar, now we are going to allow you to sleep also.
Thank you.
If you are not operating again now.
No, sir, I have to sleep.
Thank you so much, Sukumar, for being with us on this pre-Diwali night.
Thank you. Thank you, Vishal. Thank you, Bala. Thank you, friends. Good night.
Umesh is, and sorry, waiting. Sukumar, if you can stop screening.
Yeah, I'm just exiting.
Yeah.
Yeah, Bala. I've exited out.
Yes. Thank you, Sukumar. Have a nice Diwali. These talks are also being recorded and also being posted on our website and for all the others to see. So definitely, you can make use of it as well. Thank you, Umesh. Off to you.
Yeah. Thank you so much, Bala. I think if it was not any late, we would have burst crackers for all these talks. And it was, I think really I have to commend all of you for staying so late, and even the participants for staying so late on a festival night. And, anyways, I'll not take too much time. I'll be very brief and talk about what OARM adds to the value when we are planning or when we are doing any spine surgery. So we have already heard talks about navigation. We have already heard talks about robot. But you see, they are all effector mechanisms. See, ultimately, in a navigation or in a robot, they are able to perform the surgery if you give them a target. And only the target can be given only if the image is good. That is, you need a map to navigate, right? And the map is provided by your intraop imaging technique. And what better to have than an intraoperative 3D navigation, 3D imaging system. So as we know, a brief introduction, this is a Medtronic device. It's an intraoperative 2D or a 3D imaging system which procures the patient's anatomical images in all three dimensions, that is axial, coronal, sagittal, and you can also have multiple other views, as we can see in the navigation system as well. So it can be, ultimately, this is just an imaging device. It has to be integrated with a navigation system, navigation equipment, after which we can track instruments in real time, as has been shown with the previous surgery. So what does it add value? Basically, to say it in a summary, it increases the speed of the surgery because your images are clear. You will be able to see the you don't have to take multiple C-arm shots. You can navigate on a single screen rather than taking an AP and a lateral if you're doing 2D. It improves the safety and accuracy of the surgery because the accuracy, as has already been shown by our previous speakers, is very, very good with an intraoperative 3D navigation system whenever it is there. So in addition to that, it is most useful, apart from the routine cases, it is most useful in complex cases. It identifies critical structures during surgery, even when they are hidden from our direct view, especially when we are doing minimal invasive spine surgery. So OARM is a very heavy equipment. We need to understand that it is nearly around 198 centimeter, gantry. We have already had queries from people who are planning to buy this, like if their OT door needs to be changed for the OARM to enter the OT, because that is one of the main limitations in all these things. The second thing is we need to have a good table as well. We need to have a good radiolucent table because our existing tables, even though the OARM may be able to go under this, so there will be a lot of artifacts, even though you may be able to do an image. So you need to have an extension, either an extension like this to your existing OT table, or you need to have a completely radiolucent complete system like a Jackson or an Allen table that has been shown here. And this is some of the space consideration that we need to have. So basically, this is the panel that we are seeing in OARM. And you see there are a lot of possibilities, a lot of things that we can do there. It can do 2D and it can do a 3D imaging system. And as you can see, there are a lot of factors here which can be there. You can rotate the image using these factors. But main thing, these right-sided panels, what you are seeing there, the yellow colored ones, they are all the ones that are used to move the OARM. So as you can see, this is to open the ring of the OARM, and this is to close the ring of the OARM. The OARM can be tilted in case if you want the angle to be correct. This is to move it forward and backward, and then this is to change the angle of the OARM as a whole. These are for the stand. These things are for the stand of the OARM, whereas this is only for the ring. And once the ring is there, again, you see you'll be able to make it into AP and a lateral image based on the rotation of the scanner that is there inside the bulk of the OARM. You can even manually adjust these, flip these images. You can even change the the field of vision. You can change the cone of the radiation that is there. What is more important is these factors, which I'm going to show later as well. So for example, in this, we have multiple selection options. You can select the dosage, you can select the thickness of the patient, and you can select whether you want the scan in a low dosage radiation, you want the scan in a standard dosage, you want the scan in a high definition dosage, HD dosage, depending upon what you are trying to image. For example, an osteoporosis, obese, prior implants are already there. You can select a high definition scanner where the resolution will be more, but the radiation is also more. A thin patient, a routine case, not a deformity, routine, this one, you can always select a low radiation dose, which can give a relatively good quality image, as I'm going to show, but with reduced radiation exposure to the patient as well. In addition to that, you can also select the patient thickness as well. So why it matters is this. You see, this is the dosage that is delivered in a standard dosage as well as a load. It's almost it's almost one third. It's almost half in many cases. And that makes a significant difference to a patient, because in one scan, in one surgery, the patient will be exposed to OM twice. Usually, most of us, what we do is we do a scan in the beginning, do the surgery, and then check again in the end with an OM. And as you can see, in a routine case, when there is no deformity, no osteoporosis, no prior implants that are there, the quality of the scans that are available, as you can see, there is hardly any difference. And we know that we need to keep these, even for the surgeons also, the exposure within the limits. So this is the OM workflow that is there. The first step is always to drape the patient, paint, drape, and fix the reference frame. After that, we drape the OM, and we find it convenient to drape the patient, as I'm going to show in a short video later. And once the OM is brought into the operation theater, we connect it to the navigation system first. Of course, it has to be switched on, connected to the navigation system first. And we position the OM in the area of interest, whether it is lumbar, thoracic, cervical. We position it in the area of interest to capture that in a 2D image. Initially, we don't go for 3D. Initially, you take a 2D to see that the OM is in the correct position. Once the OM is in the correct position, you move to a 3D image, you select the parameters. You want a high definition, standard definition, low dose imaging. You select the patient thickness, and then you see that the OM is connected to the navigation. And the navigation is able to visualize the OM fiducials as well. And then everybody can go out of the OT, so that nobody stays inside the OT when the 3D imaging happening. So this is a short thing. This is outside our operation theater. You see, this is the door for the operation theater. All the parameters are entered outside the operation theaters. You can enter the patient details. You can select the region that you are operating, all those things. This is the monitor that is coming in. The navigation system is already inside. And once this comes, and then you see the OM can move. It's a very bulky equipment, but you can move it sideways as well as front and back. And here it is, you are bringing it sideways. And then once there is a lock in the handle, which can be used to change. So, change the angle. So this is how the OM comes into the OT. And this is how the ring opens. Once the ring is opened, then you have this is the connection that is there from the navigation system. So that is the navigation system. The connection from there, it is communicating with the OM, and then the same cable is attached to the OM monitor there. So where the OM is there, and this monitor is obviously in turn connected to the OM scanner, that is the machine. You select the server, and then once that is there, they are communicating, and that shows as a green light in that. So this is the reference frame that is being fixed. This actually is a case of MIS thoracic corpectomy, but we can fix it on the spinous process in these cases, but usually we can fix it on the PSIS as well. So once the reference frame is fixed, so this is what I was telling. So we drape the patient. We don't drape the OM, because draping the OM, drapes are more expensive, and draping is more cumbersome, takes more time. So we just put 2 sterile drapes on the patient, leave the frame open, obviously, because the frame has to be visualized by the OM, by the navigation system when the scan is happening. And that is how the patient's anatomy is registered to the navigation system. And once that is done, we just tie this in order to make sure that this is not falling off on the ground. All the sterile drapes that are draped the patient all go inside this. As you can see, you just pull the drape from the other side, and then you just drape it, as you can see there, and then tie it, so that we have created a gap there. under which the O-arm can go in. So this can be done for any, this can be done for all the way from cervical to craniocervical junction to the pelvis as well. So the same thing will apply. So once the O-arm is done, we make sure that there is nothing, no structure hindering, and then the O-arm is closed. You select the parameters as you are telling there. We can select HD. We have selected here because this is a very osteoporotic patient. You can select the patient thickness XL, whether the patient is large, very very well built, or patient is lean. Depending on that, S, XL, M, like that you can select. And then you select the AP. You see that screen is coming, that in order to measure, in order to make sure that you are imaging the correct area, you select the AP and the lateral. And once that is done, everybody moves out of the OT, and then the O-arm takes the scan inside. So there is a button which comes, there is a foot pedal or kind of a pedal that comes all the way. You can pull it through a thread. It comes outside the OT. Once everybody is outside the OT and the door of the operation theater is closed, which are also lead lined, you just press the pedal and then the scan starts. And once the scan is done, it hardly takes this much time. It hardly takes less than a minute for the scan to happen. And then everybody again goes back in. And once this is done, the navigation system captures these images from the O-arm console, and then it is readily available for navigation. And this is on the screen of the navigation. This is for a different case, obviously for a lumbar case, as you can see there, not the case which I was showing earlier. So you can see, you can change the angle, you can zoom it, you can, select whether you want a sagittal, trajectory 1, trajectory 2, sagittal, axial, coronal, probe side view. All those different images are there. Once all this is done, you can, the O-arm will go out, and then these two bands are just cut using a scissor, and somebody else, not the persons who are operating, somebody else, they pulls the drapes from below so that the sterility is not affected, and you can proceed with the surgery. Now, as I was telling, it can be used, the applications of O-arm, once you have a good image, the applications are totally limitless. You can virtually do multiple steps in the surgery using these images or good images that you are obtaining with O-arm. As you can see there, lumbar pedicle screw, minimally invasive, even in difficult cases for kyphoplasty, for the collapsed vertebrae. And then you can see there, you can use this. The first dilator also can be navigated. You get a crystal clear image of where you are going to land, where you are going to dock. Advanced cases like minimally invasive C1, C2 fusions can be done, even in difficult cases where the pedicles, or there is a C2-3 clip will feel in this case, where there is a narrow C3 pedicle, or even the C2 par screw is relatively less compromised, relatively less as compared to a regular this one. In those cases, it can be easily used a 3D navigation to do these kind of cases. Even cervical pedicle screws can be done MIS, as you can see in these particular cases, right from the planning, because you have a very good image even in the cervical spine. You can do that as an MIS case. And this is again a navigated drill, which Dr. Kulkarni was also showing earlier, which can be used to drill the cervical pedicles in an MIS manner, and then can be done. Thoracic pedicle screws, MIS, can be also be done, whether you want a standard screw here or through the pedicle, or an in-out-in technique as is being done there when the pedicle is very narrow. You can taper, you can plan, because you have a good image, you can plan using the navigation, all these things. Deformity corrections, as was being mentioned by Dr. Chhabra as well. Here, once you have a good image, the robo only uses these images to put in a screw. Your hand job is less. But here, the only difference is that we use manual thing, our own hands, to put in the screws in these cases. Lateral surgeries can also be navigated. It has already been shown. It's very useful in degenerative deformities, multi-level fixations, when you have to do multi-level OLIF, to take a good image, especially with distorted vascular anatomy, distorted or displaced vascular anatomy due to the degenerative scoliosis. It can be easily monitored. The entry level, the incisions can be easily planned using a 3D navigation technique. Multi-level or single stage lateral position OLIFs can be done, as has already been shown. Even pelvic. So right from cervicothoracic junction all the way to the pelvis, you can image irrespective of the patient's thickness, irrespective of the prior surgery, irrespective of the deformity or the pathology that is there, to obtain good images. And in turn, you can use these images. So that is the value that the O-arm adds. Unless you have a good image, The robo is not going to put in a screw using a bad image. Robo needs a good image to put a screw. Even the navigation system needs a good image to put the screw. But ultimately, we should, whatever high technology we have, we should always depend to a certain extent on our anatomical knowledge and skill. So just to summarize, OARM is an intraoperative 3D imaging solution. It is not a navigation. You don't use OARM to use during the surgery. It just takes the image and then it goes outside. The rest of the surgery happens through navigation system. These images are sent to the navigation system where the surgery happens. And as I told, it is applicable to the whole spinal axis. We can even put occipital screws with a very good accuracy, exact bicortical purchase. The length of the screws can be achieved using these. This one. We have even done sacral tumors using OARM navigation in all these cases. It obviously increases accuracy because you have a good image combined with the navigation. Of course, it, as I earlier told, it aids in faster as well as safer instrumentation. But like any other navigation system, because ultimately these images are transferred to a navigation system, you are not navigating, even though you are telling your navigation is real time, your image is not real time. Your image is virtual image, which has been taken some time earlier. So you should always be aware of registration errors and limitations of these things. Thank you so much.
Thank you very much, Umesh. There was a really fantastic overview of how useful the OARM is, and very nice videos showing practically how you can get the OARM into your theater. I really like the technique because I have struggled many times getting that OARM, the C into the patient, but I've learned something really useful now, just getting the drape and tying the drape around. That's a really nice technique. Yeah. You can also save cost of your OARM drapes.
I know, yes.
Yeah.
No, I think Umesh, I think
Yes.
this conference has, this virtual meeting of 2 hours has showed us so many aspects of instrumentation and processes that I think most of us pay very little attention to.
Yes.
And I'm sure these 2 hours have, not only for the delegate, but I have personally gained so much knowing about instruments, the checklist, the importance of equipment check before you really, and also particularly about the OLIF instrumentation checklist and the navigation systems and the OARM movement that you just showed with the OT setup that I saw. I think it's really important for all of us to master this and tame the processes that we have just seen by all the 6 super faculty members here. Thank you so much, Umesh, for a pre-Diwali gift.
Thank you. Yeah.
Of us.
Thank you, Umesh. Well, I hope it's useful. And it's time now to go back to the family and get some, something going to happen downstairs when you go down. The
So
family.
before we take part, I think this is the time we mention about all this. What you heard today is there for play or for doing your hands-on, to wash up your hands on all these equipments, including the endoscope, the tubular systems, the instruments, the implant, the cages, the fluoroscopes, the C-arms, the tables, setting up OT workshops. All this is going to happen here live, face-to-face in the event that is going to be scheduled from 8th to 10th of November. And we are looking forward to host you all. It is surely turned out to be one of the best, finest, and most looked after sort of the workshop for all the equipments and training in armamentarium of spine surgery. But before we reach out there, we have another very, very important communication presentation workshop on the 6th of November. We look forward to host you and see you all there on the 6th November again from 7 to 9. Over to you, Bala, for the vote of thanks.
Yeah, thank you. So I'd like to thank all the delegates for staying back. Until about half an hour ago, there was about 45 of them. Plus, it's on OrthoTV. And then I'd like to thank especially all our delegates, especially the last player, the final batsman, Umesh, who stayed back. I know it is pre-Diwali, and I hope you all go enjoy your Diwali. Be safe. And burst crackers and enjoy Diwali. And we'll see you all next Wednesday. And all the delegates who have registered for the spine boot camp, look forward to seeing you in Mumbai on next Friday. And those of you who have not registered, this is your opportunity for you to register, because everything that you saw today, you heard, is going to be a live workshop. With that,
and special thanks to OrthoTV team, Dr. Neeraj, Bijlani, and Ashok, Shyam, for being our media partners and spread out partners. They are the real true time global outreach partners for all academic meetings. Thank you, OrthoTV. The whole OrthoTV team, thank you so much for being around.
Thank you so much. Thanks, Vishal. Thank you. Happy Diwali to everyone. Bye, Umesh.